So these are going to be nephritic disorders, but I'm also going to talk about vasculitis syndromes and, well, some of the vasculitis syndromes and also nephrotic syndrome. So when you're thinking about nephritic syndrome, it looks a lot like acute kidney injury, maybe acute tubular necrosis, but the thing that separates it for you on the test is going to be red blood cell casts and fragmented red blood cells, suggesting a glomerular injury. These are usually pretty inflammatory in nature. They're associated with lots of inflammatory conditions also. And they do have some proteinuria, but it should not be up to 3 or 4 plus range where nephrotic syndrome is, but they can be. And we'll go through the syndromes now. Symptom-wise, hematuria, high blood pressure, edema, super non-specific. So again, this finding here, the fragmented RBCs and RBC casts are what's really going to help to is what are really going to help you nail this down on your test. So first thing, somebody had a URI, and a few days later they come in and now they've got red urine and hypertension. So post-strep versus IgA. How do we differentiate them? I think this is a pretty good summary of it right here. If it's strep, it's usually about 7 days or 10 days afterward, whereas with IgA nephropathy, the hematuria usually starts during the course of the URI. By the same time they're starting to get a cough with their URI, they're probably going to start having some blood in their pee. And post-strep only happens once. You're not going to get it over and over again. Somebody with a history of similar episodes sounds like IgA. And if they don't give you enough information, one thing very specific for post-strep disease is a decreased C3 complement level. All right. So with lupus, you can have either a progressive nephritic syndrome or nephritic syndrome that sort of flares up and down with the disease itself, or you could have a nephrotic syndrome due to membranous nephropathy. So if they have proteinuria up to 3 or 4 plus level with no change in their creatinine, then you're dealing with membranous nephropathy in a lupus patient. But if they do have a nephritic picture, not nephrotic that is, then how do we tell? So the obvious way is if somebody has symptoms of lupus like the malar rash and serositis, and it's right there in front of you, but a lot of times they're not going to give you that much information. So keys to finding it, if you're lucky, positive ANA and double-stranded DNA, that would really help. But really, one of the things that can really separate this nephritic syndrome away from others is that they have decreased C3 and C4 levels and total serum complement. Okay, so if you have that, in addition to positive, seropositiveness, then, or even a polyarthralgia and a mild skin rash somewhere, slam dunk, it's lupus nephritis. So Goodpasture Syndrome, or anti-GBM disease. All right, so antibodies that attack the basement membrane of the kidney and also attack the lining of the lung and the alveoli. So they usually present with hemoptysis, and at some point during their evaluation, they have either hematuria or you notice that the creatinine is elevated. But the key here, separating it from some of the other vasculitis syndromes, is that it does not affect the upper airway like the sinuses or the nose. All right, so it's all going to be in the pulmonary parenchyma, and you're going to see on X-ray diffuse infiltrates, and that's going to represent likely alveolar hemorrhage. These people, the vignette might tell you that they've been treated unsuccessfully multiple times for a pneumonia. That would suggest that this is maybe not an infectious process and that you're maybe dealing with an autoimmune type syndrome. And when somebody's having a flare of Goodpasture syndrome, if they give you a positive anti-GBM antibody, you've got it. But what's the acute treatment? And the acute treatment is 3 things. You want to take their plasma out and exchange it, plasmapheresis. You want to start IV steroids and cyclophosphamide. So now on the next slide, we talk about some of the different vasculitis syndromes that cause acute kidney injuries and nephritic syndrome. And the treatment for those is the exact same as it is for Goodpasture syndrome. Okay? So somebody has Wegener's granulomatosis, or as they call it now, granulomatosis with polyangiitis. These people usually have very prominent upper airway involvement, and that right there separates it from Goodpasture disease. And typically, they may give you a picture on the exam with a saddle nose, but they may not. And the problem with Wegener's disease is that it is just like microscopic polyangiitis. So on your exam, the two diseases both involve the upper airway, lungs, kidney, they both cause skin lesions. So how do we tell them apart? They have to give you a biopsy, or they have to give you C-ANCA specificity. And if they do that, you can separate it. So with Wegener's, they're going to be C-ANCA positive, and with microscopic polyangiitis, they're P-ANCA positive. So that information has to be there, and it's going to be a long, disgusting vignette, but if they give you that information, you're going to get it right. P-ANCA for microscopic, C-ANCA for Wegener's. That's it. And then Scherg-Strauss I threw in here, isn't necessarily as prominent with regard to involvement of the kidney, but somebody who has a history of asthma and peripheral elevation of the eosinophils with a vasculitis sort of picture and a positive P-ANCA, that is Scherg-Strauss syndrome. And I'll tell you what, I always forget what Scherg-Strauss is, and then I'm reading the question, and they have this elevation of eosinophils, and it's just, what the heck is, it's Scherg-Strauss. So just remember that. There's always going to be elevation of eosinophils in a history of asthma, and that should help you get it right. Then Alport syndrome is something to remember. Just a header. Usually the disease is not too severe early on, but they may have a history or family history of renal failure. That's a key link to it. It's usually going to be a male since it's X-linked. And the classic thing here that's going to help you figure it out on the test is they're going to tell you that there's hearing loss. So why am I pointing this out to you? Because you probably already knew that. Is that I could see them presenting Alport syndrome to you on the test as somebody who has hematuria recurrently after a URI. And that sounds just like IgA nephropathy. Okay? So the key here is that if you see evidence of hearing loss in a syndrome that looks like IgA nephropathy, you should think Alport syndrome. And very quickly, I wanted to summarize the different nephrotic syndromes and the associations that might help you figure out which one they are. So diabetic nephropathy, I don't think we need to go over. I think you'll get that. So FSGS has an association with HIV. Make sure you know that association. It's also the most common idiopathic nephrotic syndrome. Of course, diabetic nephropathy is not idiopathic. We know how they got it. And know for membranous that it's associated with lupus, as we already mentioned, and also hepatitis B, and certain medicines like gold or penicillamine. And for amyloidosis, just know the underlying cause. AA amyloid is an acute phase reactant. So these people get amyloidosis in the kidney after having like rheumatoid arthritis or any long-term inflammatory condition with antibody production could cause AA amyloidosis. AL amyloid is associated with multiple myeloma. It's light chain, so L for light chain. So you got it.